Today we'd like to talk about the ongoing confusion tied to Incident to billing. Over the past 15 years, the leading topic causing confusion in medical practices just might be something that's called Incident to billing. At least that's my perception as someone who's responded to questions on this topic on a regular basis. What is Incident to billing? Well, it's when the claim for payment is submitted under a physician's name and NPI number when a mid-level provider, such as a nurse practitioner or a physician's assistant, actually performed the service. One reason for doing this is that when billed under the physician, the claim is usually paid at 100% of the payer's fee schedule, rather than at the mid-level's pay scale of 85% of the contract allowed amount. This is according to the rules of Medicare, which most private insurances also follow. Incident to billing dates back to a time when mid-levels were far less prevalent in the marketplace, and third-party payers didn't recognize mid-level providers for enrollment of credentialing in their plans. It was a way for the physicians to employ extra help and get reimbursement for the work being done. Back then, all the claims were reimbursed at 100% of the fee schedule. Eventually, the third-party payers realized that, from their perspective, there may be a better way to do this. They came to the conclusion that they could enroll mid-level providers in their plans and then pay them only 85% of what they were paying physicians. Of course, a sweet deal for the insurance companies and a pay cut for the medical practices. While Incident to billing is still a viable option in cases where it makes sense, there are some strict rules that must be followed. First, payers say that if someone can be enrolled or credentialed, they should be enrolled and billing should be done under their individual NPI number, period. That's the way they want it done. But there are still some situations that may justify Incident to activities. Perhaps the mid-level's credentialing is in process, but he or she is already working in the office. Or, where we do business in Iowa, Medicaid does not recognize physician assistants. Therefore, the only way they can see an Iowa Medicaid patient and be reimbursed for the service is by using the rules of Incident to billing. Regardless of these and other reasons, the typical motivation is the desire for the practice not to lose that 15% of reimbursement. And most payers have left the door cracked open just a little bit, allowing Incident to billing if specific rules and requirements are met. In our opinion, the extra 15% of compensation comes at a high price in terms of having to follow these complex rules. There's also the creation of additional administrative burdens necessary to do it right. For example, the service by the mid-level must be done during the patient's normal course of treatment, during which a physician personally performed an additional service for the specific problem or problems. The physician has established a plan of care and remains actively involved in the patient's ongoing treatment. The rules state that the physician must also be available to provide direct supervision. While the physician does not have to be in the exam room with the mid-level while the service is being provided, he or she must be present in the office suite to provide assistance if needed. In other words, if the billing doctor leaves the office to perform hospital rounds, perform surgery, or for any other reason while the patient is being seen by the mid-level provider, the rules are violated and the service should not be billed under the supervising physician. The fact that the physician must initially treat the patient for a specific problem and then create a plan of care to be followed by the mid-level creates some challenging administrative hurdles. Employees scheduling clinic resources must be aware of the situation and make sure that they do not schedule a new patient or an established patient with a new problem or complaint. If a patient brings up a new problem during a visit slated to be billed Incident to, it cannot be billed in that manner. The real concern is that violation of these rules can be construed as fraudulent billing being done just to get that extra 15% of compensation. And one final issue is the potential confusion of your patients. Many may not understand why their follow-up visits do not involve the original physician, possibly raising concerns about continuity of care. There is potential for even greater confusion when the patient receives an insurance company explanation of benefits that indicates they were seen by the doctor, not the mid-level who actually provided the service. Over the years, we've experienced this on many occasions and have had to explain these circumstances on behalf of our billing clients. In some cases, patient-generated calls to the insurance company raising concerns about who actually saw the patient has resulted in scrutiny by the payer to determine exactly what procedures were followed. We've touched on some of the high spots related to Incident to billing. Our best advice is to review all of the rules before billing Incident to for mid-level providers. They do vary from one insurance plan to another. In Iowa, even Medicare and Medicaid are not exactly the same. Make sure you are not violating your contracts with Medicare, Medicaid, and private insurance companies. Follow the rules of each payer with precision. Not doing so can result in some serious problems. And remember what we always say at Medical Billing Services: you practice medicine and we'll do the rest.